Hi everyone, very happy to record this session this morning with you and to be able to discuss let's say the modern vision, not really humble, but let's say we're gonna drive through the last element that I can teach you about high tibial osteotomy in the varus knees. A lot of that is coming from two people. The first one is Sébastien Parat, which was my mentor, which is my mentor, but was my mentor in my department some 10 years ago. And he was the one that gave me my PhD project. And at this time, it was a project on patient-specific instrument cutting guides for TKAs for Zimmer. And after only 1 year of studying this PhD, this paper comes out, the Joint Award of this year, saying that in UKAs and in TKAs, those patient-specific guides were completely useless. So the problem was that after only 1 year of work, we have 5 different papers, but a project that was stopped. And everybody rushed into that and say those PSIs were very non-useful tools in TKAs. Still, I had to do something, and I asked them, what is the next step? How do we move forward on these patient-specific printed guides? And he said, you know what? Tibial plateau fractures. We need to do something for the malunions of the tibial plateau fracture. And we created that just after that. And we discovered, because of that, the concept of osteotomies. So hard to imagine, but in 2015, my knowledge about osteotomies was zero. And this guy, Christian Clay, was the one that taught me that. After a congress, I presented our first patient-specific cutting guide outcomes, our first 100 in 2017. And at the end of the talk, this guy, Christian, came to me and said, you know nothing, Jon Snow. Your knowledge about osteotomy is zero. And I'm going to teach you. And the best thing about it, when you will be trained, those patient-specific cutting guide will be not useful at all in your life. And he was right, because we published last year this case paper saying when you're trained, it's not necessary to use them anymore, but it is the best tool ever created to be trained anyway. So now the plan for today, how to make high tibial osteotomy great again in America. I know this sentence is pretty, let's say, controversial, but let's do it anyway. We need to know what is normal. We need to know what should be the best correction, what is the algorithm of correction and planning, the tips and tricks to do easily high tibial osteotomy, and finally some nightmares that we try to avoid during the surgery. Because remember, and it's true even in this plan, this is Antoine Saint-Exupéry's sentence: a goal without a plan is just a wish. What is normal? This is the books that are on my table actually nearly every day. The book we publish on the osteotomy in French, I'm sorry about that. The Drop-Early Principle of Deformity Correction, the Lobanhofer and Van Leeuwarden Osteotomy of the Knee for AO, and the book of Mackie Wentz, which is the #1 and first ever published book on the osteotomy. This is the normal. We published that with Soma database some 3-4 years ago, 2017, I guess. Saying that in 2000, normal healthy knees, MLDFA was 87, MPTA was 87, GLO is 0 to 2. That is a big thing. That means that every single healthy human beings had 3 degrees of valgus in a femur, 3 degrees of varus in a tibia, and an oblique joint line of 2 degrees. Knowing that, you can start saying that if there is something which is, let's say, more than 2 standard deviations to those normal elements, you potentially want to correct it. Because the key of osteotomy is this one. The indication of knee osteotomy is metaphyseal deformity. It is the key indication of everything. And if you have an intra-articular deformity, a full medial anteromedial thickness defect, the best option is, of course, doing a partial knee replacement, because the osteotomy only aim to correct deformity which are outside of the joint and create issues inside of the joint. More than that, now we have let's return back for a minute on that. We have the MLDFA, we have the MPTA, we have the GLO. The last angle is here, the GLCA angle. This is the nasty one. And everything indication is based on that. And I will show you why. Because this GLCA angle is the reducible part of the deformity. It is what we call the last soft tissue laxity. And it also defines the intra-articular wear. It is the best continuous value that predict the evolution of arthritis. So if you have you have a very important substantial GLCA, you have a big intra-articular deformity. If you have a zero or neutral GLCA, you have no deformity. And of course, if you have deformity, this deformity is outside of the joint. And there is a complete clear correlation that we published in MEDSTAR 2 weeks ago in between the GLCA and the Halbach or Kellgren classification. The bigger it is, the highest the chance to have a major intra-articular defect, and then, of course, a very high grade of arthritis rated by Halbach or Kellgren and Lawrence deformity. I will even say that if you are more than 6 degrees of GLCA, probably you have a very big intra-articular defect, and probably your HTO outcomes will be pretty unpredictable. But if you have a very low intra-articular deformity, less than 3, you have potentially a big extra-articular deformity. If you have 10 degrees of varus, 7 will be outside of the joint and 3 inside of the joint. So the osteotomy will work very well. I will even say that you can create a kind of deformity locator based on this equation. Arithmetic HKA, which is the extra-articular deformity, MPTA minus MLDFA, plus 1, divided by GLCA, plus 1. Why the plus 1? Because GLCA can be 0, and it's tough to divide things by 0. It's a mathematical error. So if you have a deformity location which is less than 1, that means that you have a bigger intra-articular deformity than the extra-articular deformity, and you need probably to rethink the indication of knee osteotomy and go for something more intra-articular. If you have a deformity located which is more than 2, that means that you have twice more extra-articular arthritis, that you have intra-articular deformity, extra-articular deformity, that you have intra-articular deformity, and then osteotomy could be indicated. And if you're in between those 1 and 2, you're in the gray zone. Example 1, this is a classic patient for HTO, MPTA 81, MLDFA 88, GLCA 1, meaning that he have 7 degrees of varus inside of the tibia, 1 degree of varus inside the femur, and nothing inside the joint almost. The DL is 7, that means that the HTO is a very good indication. Example number 2, MPTA 86, normal, MLDFA 92, varus in the femur, 5 degree, GLCA 7. His deformity locator is around 1, that means because it's a 5 divided by 7. So of course you have a very high risk of doing mistake if you do HTO. One being that potentially you're going to correct in the tibia something which is in the femur, or even worse, in the femur plus in the joint. And you will see that you have a major complication, which we call soft tissue laxity or soft tissue correction, that can create massive overcorrection in these specific scenarios. Question 2, so we know now what is normal, we know what to correct. What is the ultimate correction? This is Patrick Chabran, the chief of the mechanical department of my hospital, and he only focused on mechanical problems. I focus on both anatomy and mechanics because I'm a surgeon. And the idea is, if you really look at this, this is the Fujisawa paper. So the paper that defined what should be the post-op position of the joint line, pre-op to post-op, shifting the weight-bearing line in high tibial osteotomy when you do HTO for varus knees. But look at that. First, he evaluated in arthroscopy the cartilage. Second, he did HTO in very, very bad scenarios with mainly intra-articular deformity and massive GLCA. Let's say here is something above 7 or 8. And he said that to completely correct the mechanical problems and release the patient from pain, you need to overcorrect to an extent which is about 6 to 8 degrees of valgus with a Fujisawa point, which is around 65 and 70% compared to the global tibial plateau width. But remember, look at that. This is not an indication for HTO. This is an indication for TKA or UKA. So it's because it's a very old study and a very old series that this was the knowledge at this time where TKA didn't exist. Then the Americans, Dugdale and Noyes, they came and said, you know, those 60 to 70 is not very easy to understand. Let's focus on the 62.5%. And you can argue that it was very nice, but it's completely, and admitted by the author, empirically decided. So they thought that 62.5 was a good point, and they stick into that. And for decades, everybody look at this number like the golden numbers without being pushed by any basic science or clinical evidence. Now, what do? We look at the tibial spine. Why? We return toward the center. We return toward the mean of the healthy subject. So if you want to correct, probably you need to overcorrect slightly the varus knees into something which is 182 deformity in valgus, or 55% for the Fujisawa point or the Dugdale-Nose point. We go from 70 to 55. So it's a big shift to the middle. And lucky us, Mother Nature gave us a magic landmark, the lateral tibial spine. In ethnicity, any age, any gender, the lateral spine is 55% of the tibial width. So it's the perfect 55% Fujisawa point. And we published that last year in the French journal. Why is it important to discuss that? Why going from 70 to 55 is something big? Because the correction will influence the aspect of the tibia after the surgery. The more you correct, the more the tibia will be a tibia valga at the end, which is not existing in human being. If you really look to your patient, look how many of them got more of 91, 92 MPTA. For me, it's maybe once a year, and I do for them decorrection, varization osteotomy. And more than that, if you look to my database that we published in Kesta last year, half of my patients were corrected the wrong bone. And I will say potentially correct point, because there were no good indication like 5 to 6 years ago when my knowledge of osteotomy was so bad, like Christian Clay said. And more than that, we know that the problematic varus is the femoral one, because everybody got tibia vara. All of us got 3 degrees of varus in the tibia, so we adapt some far better to the tibia vara than the femur vara. And if you have tibia vara, I do think that you have the best option to have a big onset of arthritis very young and finish with a TKA. The tibia vara will be tolerated by your body for years. And so first point one, we do HTO in patient with normal tibia. Point two, we do HTO when the femur was abnormal, which is the worst part of that. And it's even what we said in the ESCA consensus last year. We don't want to push the knee anatomy, the tibial anatomy. So at the end of the surgery, you should have an MPTA below 94 degrees and a jointal obliquity below 5 degrees. It's not coming from nowhere. This is the starting point of the bad things. And we know that if you do wrong side correction, this is a paper we published in Kesta, if you even ask an automated software to decide which patient is a good or bad indication for each year, you see it even in my practice. I create a lot of abnormality. This is a patient of mine. Look at this bad MPTA. You have an MPTA of, you have an obliquity of the joint line of 4.5 degrees, and I leave a deformity of the femur of 4 degrees because the MLDFA is over 90. So here you have a massive creation of abnormal femur, of abnormal tibia, leaving an abnormal femur, and this is the key for obliquity of the joint line, which will lead to bad outcomes. Because joint line obliquity is a bad thing. Return to this patient. Remember, once again, it was a perfect indication for UKA, but of course, somebody very clever, a surgeon said, we're going to do an HTO. It ends up with 20-degree correction for a normal HKA. And finally, final MPTA is 103. Of course, the femoral deformity was left like it is, and GLCA completely correct from 7 to 0. Finally, what happened? This poor guy got 10 degrees of valgus. Why? Because the surgeon take into the tibia the femoral deformity, the intra-articular deformity, and the overcorrection he intended to create. So done globally a 17-degree correction in a tibia which was normal, and completely had a soft tissue correction, and we're going to come to that. So the GLCA completely nullified, having an extra valgus deformity inside of the joint now. And finally, the patient got 10 degrees of valgus and is very unhappy. You can also notice that there is a hinge fractures that probably worsen the outcomes of the patient at the end. 3 degrees of jointal obliquity is enough to have bad clinical outcome. 6 is enough to have bad radiological outcome, so early lateral arthritis. And it is published in the AGSM by this Korean team, and it is, for me, the only good paper to analyze what happened with big GLOs. And how to avoid that? This is my new hope, Christian Clay Walker. Because DLO is the perfect tool. We just correct the deformity where it is. We don't do massive correction. We don't have issues with the correcting the tibia where the deformity is in the femur, and we really accommodate to the anatomical deformity more than the mechanics. Evidence there is. We published so many papers on the subject now, and in my activity in 2023 already, I've done 121 varus osteotomy, and a third of them were performed on the femur in DLOs or DFOs. So then what is the algorithm of correction? Because we know that we don't need to overcorrect. So we know that 55% is enough, 182-degree HKA post-op is enough. We know that we should focus at the deformity where it's supposed to be corrected, femur or tibia, or maybe nowhere with UKA. So what to do? So we have this automated software that answer the question on my dataset, and it's very easy. No brainer. You have a lower limb invarus. If the deformity is in the tibia, you do an HTO. If the deformity is in the femur, you do a DFO. If your deformity is combined, you do a combined correction. And of course, you need to fix limits and thresholds. The MPTA pre-op should be below 85, which is a starting point for varus deformity. And the post-op aspect of the femur, if you don't touch it, should be below 90, meaning that you have a normal femur. You can ask a software to do that, which is, I think, the best option. If you don't know, this is a PicMed, a software that I'm using every day from a Portuguese friend. You know that I'm calibrating the X-ray, very easy, 20 millimeter. Then the software asks me to do some corrections. I want to do a right or left knee osteotomy. I blend the system for the kind of osteotomy I want to do, so it will decide for me. I just put some points, center of the femoral head, top of the femoral head, center of the femoral head, sorry, top of the femoral head, top of the grid truck. You see that on the left side that the points are defined by the software, not by me. Medial condyle, lateral condyle, medial aspect of the plateau, lateral aspect of the plateau. And to have the tibial width, we have the two border of the plateau, lateral border of the plateau, medial border of the plateau. The last thing we need to do is to have the ankle point. And to do that, we draw two points defining the talus superior aspect. And the software gives me the answer automatically. So this is what I have. And I have a MPTA of 82, MLDFA 88, GLCA 0. So I asked him to do HTO. I just have to draw my HTO point because the deformity was the tibia. The software tell me that. And then I asked him to correct at 55%. Here is 50%. I will put to, let's say, 60% to have a big correction because this guy got the big deformity, but 55% is, of course, the best option. And the software gave me the distance I should create, which is 10.5 millimeter inside of this tibia. Why it is complex to do soft tissue correction? Once again, because you don't know what will happen pre-op to post-op. The tibia will be like this at the end or like this at the end. And the only answer we have on that is we don't know. So this is something that is probably related to the final aspect of the tibia, what we call the tipping point of Steven class. And you will see that the delta GLCA, the amount of intra-articular correction in my series, is really dependent of the value of the MPTA. The main key factor is if you correct the MPTA over 92, you have a high risk of having intra-articular correction. If you do that, you can use Christian Clay formula, GLCA minus 2 divided by 2, that should be removed out of your correction to avoid this massive extra correction. Example, we have a GLCA of 6, which is, once again, a pretty bad thing to think about neostomy, but let's take we have that. Want to do a 10-degree correction, GLCA minus 2 divided by 2 equal to, we finally do 8. So we know that whatever happened, we have a slight undercorrection or a slight overcorrection, but no risk of having this 10-degree valgus at the end. My tips and tricks for tibial osteotomy. First, cuts. Very easy to define. The cuts for the femur on the tibia is always supposed to be 110 degrees compared to the lateral border of the tibia or the medial border of the femur. Why? Because it's the ideal position to position a plate below with enough screw above and high enough not to cut at the diaphysis, which is, of course, creating potential issues of bone unions. 110 degrees is the golden number of osteotomy. Second, how do you create a hinge? You need to create a hinge which is far higher than the last third of the fibula. Why? Because it is the locking point of the osteotomy. The worst thing, my worst complication in osteotomy is the unintentional slope changing. I don't want to have major slope after surgery because I put the open only the anterior part of the tibia onto the distal one. I want to have very neutral slope at the end because I'm afraid of having problems. So to do that for point one, you need to cut above the tip fib. Otherwise, you have this locking point behind that locked the correction and locked the opening of the posterior aspect of the tibia. Second, the hinge should be then as anterior as you can, very close to the gurgit tubercle, because this situation helps you to open from behind and be able to stabilize the slope. How to do that? You shoot a key wire and between the Gerdy tubercle and the ALN insertion to protect the sewing process, to avoid the sew to get through this point. And you have a nice soft point, which is your box opener that will allow you to do at this time, this HTO is opening, but at the same time doing it from behind to avoid the slope changing problems. And because the angle, and more than that, the more detrimental factor. So we know that in the frontal plane, we have this 110-degree correction, but in the sagittal plane, you need to be parallel to the slope to avoid disasters. And how to do that? This is my technique. You can see here that I look at my superior X-ray, and you see here I see the joint line like a bubble, a convex aspect. I will flex my knee slightly and see I only have a thin line here. And this thin line give me I know that my X-rays are completely parallel to the slope. So if I shoot two key wires completely parallel to the slope, that's superimposed on my X-ray, I know that the job is done, and I will not have this kind of X-ray with big ascending cuts that create disasters. Then, next thing, what is the next step? The wedge position. The wedge should be as posterior as you can. You need to insert your wedge at the posterior aspect of the tibia here to create only posterior openings. Because otherwise, if you do anterior openings, you see here at the distal aspect, the lower shims, that you create +6, +10-degree slope without not thinking about it, and this is bad. So as posterior as you can. My nightmares to conclude: hinges, I would say that it's a bad thing. Slope changing is the worst, and void is a very easy discussion. Do we need to fix the hinge? Yes, you need to fix it as soon as you think that you're in trouble. If you hear a crack, if you see something bad on X-ray, even if you're on the tibia, you fix it. Here, for example, my hinge was broken, and you see this is my pre-op immediate X-ray, putting a screw inside, post-op X-ray, fixed and healed, job done. If you really know that you're going to have a big issue, for example, here we have a 5-degree opening of the femur. I put a preventive plate to do the opening. Same thing in this closing wedge for these young kids. I put a preventive 8 plates to control my hinge and avoid the breakage, which is working even better than having. And of course, if you don't want to have that, just put a key wire crossing the hinge, enhancing the hinge resistance by the strength of the key wire, which is about 800% usually compared to the bone. What's wrong in these cases? Refer to me. Look at that: 5-degree varus pre-op, 2-degree valgus post-op. The patient is completely unhappy. He's very painful, don't know what happened, and very angry. Bone scan is fixing at the posterior aspect of the proximal tip fib. How can you have that? Tough question. Because you have this massive reverse slope now, and everything converged to be at this exact position at the top, in between the plateau and the tip fib. Hold the strain out there. And to avoid that, I would need to do a decorrection of the slope, a deslope osteotomy for iatrogenic issues, which is, of course, bad. So control the slope. And to do that, you can refer to our recent GSM paper. You need to have a bigger opening posterior than anterior. Let's say 2/3 posterior, 1/4. Let's say 3/4, 1/4. So if you open 10 behind, you need to have maximum 3/4 millimeter anterior. And you do that with a ruler, and you really check that. And you can see here my wedge, when I allograft, it's a very triangular shaped allograft in both plane, anterior to posterior, medial to lateral, it's a triangle. Void fillers, I would say, don't believe industry partners. They are always misleading you. 4 years, no resorption. 3 years, no resorption. 2 years, no resorption. 4 months, bone blocks, allograft, complete resorptions. Don't believe synthetics. Use the real one. Don't use the copy. And we just did this webinar last week. So if you want to learn more about the wedge and the concept of wedge and feeding the wedge with my 2 friends, Christian Clay, Stephen Klass, and my good friend moderator, Etienne Cavagnac, we do a full webinar on that. So if you really want to know about void, it's completely open, and you can watch that online. Happy to discuss now. I think if anybody wants to join and visit me, osteotomy is one of my key things. I think I'm doing 150 osteotomy, 300 ACL every year. If you want to know and discover stuff with me, happy to receive. I know that it's a long trip from Washington, but anyway, I think it's worth it. We have a very nice city, best food and best wine in the world. What else? Thank you, guys.